Good afternoon everyone. I am Dr. Maya, JR from General Medicine, presenting clinical features, the symptoms, management and care of organophosphate poisoning. Clinical manifestations and mechanism. We read receptor-based clinical manifestations, time-based and the organ-based clinical manifestations. Receptor-based clinical manifestations are mainly organophosphorus act through the peripheral receptors and the central receptors. The central manifestation, that is anxiety, restlessness, ataxia, convulsions, insomnia, dysarthria, tremors, coma, respiratory depression, circulatory collapse. These manifestations occur mainly through the muscarinic receptors that are mainly present on the central nervous system. In central nervous system, all the muscarinic receptors are present along with the nicotinic receptors. Sludge symptoms, that is salivation, lacrimation, urination, defecation, GI upset and the emesis. These also occur through the muscarinic receptors, that is mainly through the peripheral muscarinic receptors, mainly M2 and M3. The neuromuscular symptoms, that is fasciculations and the paralysis, acts through the N1 nicotinic receptors that are mainly present on motor end plate. Sympathetic manifestations, that is increased heart rate, tachycardia and the hypertension mainly occur due to the N2 nicotinic receptors that are mainly present on the ganglia of the parasympathetic nervous system. Time-based manifestations, that is acute manifestations, delayed manifestations and the late manifestations. Acute manifestations occur within minutes to 24 hours, that is muscarinic, nicotinic and the central manifestations that we already discussed. Muscarinic, that is sludge, bradycardia, hypotension, meiosis and the bronchospasm. Nicotinic actions, that is weakness, fasciculations, cramps and the paralysis. Central manifestations, that is anxiety, restlessness, convulsions and the respiratory depression. Delayed manifestations, which occur between the 24 hours to 2 weeks. Late manifestation, which usually occur beyond 2 weeks, that is type 3 paralysis, which we will discuss later. Cerebellar manifestations, ocular and the ENT manifestation and the neuropsychiatric manifestation block. In organ-based manifestations, first we discuss respiratory manifestations. Patient might have a direct effect on medulla and the midbrain, that is decreased respiratory drive and glial cell inflammation. Patient might have muscarinic cholinergic stimulation leading to bronchospasm and the bronchoria. Possible increase of pneumonia secondary to cholinergic disruption of immune system. Patient might have nausea and vomiting. Stimulation of muscarinic receptors can increase gastric acid secretion, which further leads to risk of aspiration. Patient can have decreased phrenic nerve activity and therefore decreased diaphragm contraction, increased alveolar fluid and increased pulmonary capillary permeability. Alveolar hemorrhage can be there. Increased alveolar protein, neutrophils and inflammatory cytokines, which further leads to ARDS-like picture. Overstimulation of the skeletal neuromuscular junction causes fasciculations and paralysis. There is also risk of increased risk of pancreatitis and the ARDS-like picture. Neurological manifestations. 3 different types of paralysis are recognized based largely on the time of recurrence and their different pathophysiology. Type 1 paralysis or acute paralysis, type 2 paralysis or intermediate syndrome, type 3 paralysis or organophosphate induced delayed polyneuropathy. Type 1 paralysis or acute paralysis, this is seen during the initial cholinergic phase. This is when large number of both muscarinic and nicotinic receptors are occupied acetylcholine, leading to persistent depolarization at the NMJ neuromuscular junction. Clinical features include muscle fasciculations, cramps, twitching and the weakness. At this stage, patient may require ventilatory support due to the weakness of respiratory muscles, leading to respiratory depression and the arrest. Type 2 paralysis and the intermediate syndrome. This is a distinct clinical entity that occurs 24 to 96 hours after the ingestion of OP compound. Approximately 10 to 40% of the patients treated for acute poisoning develop this illness. The onset of intermediate syndrome is often rapid with progression of muscle weakness from the ocular muscles, from the neck muscles, that patient not able to flex the neck, with involvement of proximal limb muscles and ultimately leading to respiratory muscles involvement, that is intercostals and the diaphragm, which occurs over the course of 24 hours. Type 3 paralysis or organophosphate-induced delayed polyneuropathy, which usually occur sensory motor distal, that is sensory motor distal axonopathy, that usually occurs after ingestion of large doses of organophosphate compound. The neuropathy presents at weakness and ataxia following a latent period of 2 to 4 weeks. Initial stimulation causes excitatory fasciculations, which often progress to inhibit cause paralysis. The cardinal symptoms are the distal weakness of the hands and the feet. This is often preceded by calf pain and in some cases paresthesia of distal part of the limbs. Delayed CNS signs are tremors, anxiety and the coma. Other organ specific manifestations are cardiovascular complications, that is hypotension or the bradycardia. ECG manifestations include prolonged QT interval, elevation of the ST segment, inverted T waves and a prolonged PR interval. Rhythm abnormalities such as sinus bradycardia, ventricular extrasystoles, ventricular tachycardia and the fibrillations. Now we discuss the management of OP poisoning will be reduced. Diagnosis of OP poisoning. Diagnosis of OP poisoning is mainly based on history of exposure to organophosphorus compounds, characteristics, manifestation of toxicity, and the improvement in sign and symptoms after administration of atropine. There can be pungent garlic-like smell. Toxicology analysis of the secretions, that is gastric secretions, blood or the urine sample, serum and pseudocholinesterase level in the patient's blood samples will be reduced. However, in doubtful cases and especially if lab facilities are not available, we give 1 milligram of atropine intravenously. If this doesn't produce marked anticholinergic manifestations, then anticholinesterase poisoning should be strongly suspected. The treatment part. After initial stabilization of the patient, that is airway, breathing and the circulation, only after patient is stabilized we go for decontamination and the other supportive therapy. In supportive therapy, we had blockade of muscarinic activity, that is with atropine, reversal of cholinesterase inhibition, that is done with the help of AIIMS, correction of metabolic abnormalities, prevention of infection that might be needed in patients with patients who need prolonged ventilation, and management of complications. Decontamination and the supportive therapy. Patient to be kept in left lateral position with necks extended. This help to prevent the aspiration risk in the patient. Remove the clothes and clean the body with soap and water. Gastric decontamination is done by forced emesis if the patient is awake. We should avoid forced emesis if the patient is if patient is unconscious. Gastric decontamination can also be done through the gastric lavage. Care should be taken by the health professional to avoid decontamination. OP poisoning patient, if presents within 2 hours of ingestion, if patient is conscious, we should go for gastric lavage with the activated charcoal. If patient came in altered sensorium, then we should secure the airway first through intubation. Then we should go for gastric lavage and with activated charcoal. If patient present after 2 hours of ingestion or if the patient is conscious, then we should go for again the decontamination part. If patient is in altered sensorium, then we should secure the airway first, then should go for decontamination. The management part. It includes the 4 components, that is decreased absorption. Absorption of toxin should be decreased through the skin and the gut. After absorption, the organophosphorates make compound with the acetylcholine esterase enzyme and it acts on the various organs. It acts on heart and causes arrhythmias and long QTC interval. It acts on muscles, causes oxidative stress. Acts on respiratory group of muscles, causes bronchoria and the bronchospasm, and on the CNS causing respiratory depression and the seizures. These are the various organs, that is atropine, diazepam, clonidine, adenosine and the other group of drugs which modulate the effect of this organophosphorus on various organs. Third part is, that is we can neutralize the toxin by AIIMS and the butyryl choline esterase enzyme and the albumin, which is present and which can be provided through fresh frozen plasma. Other than that, we can enhance the elimination of the toxin by alkalinization, by the hemoperfusion, or the bioremediation, which uses the hydrolysis enzyme which hydrolyze the organophosphorus compound. Atropinization, we obtain IV access and give 1 to 3 milligram of atropine as a bolus depending on the severity of clinical manifestations, followed by infusion rate. Our aim is to keep the systolic blood pressure above 80 mmHg and the urine output above 0.5 ml per kg per hour. We record pulse rate, BP, the pupil size, the presence of sweating and the auscultatory chest findings after the first atropine dose. We review after 5 minutes. If after 5 minutes response is not there, then we have to double the dose. We have to review every 5 minutes. Once parameter have begun to improve, then we can cease the double dosing and we can continue with the same dose, or the smaller doses can be used. What are the target endpoints for atropine therapy? Clear chest on auscultation with no wheeze is the best sign for of atropinization. Heart rate more than 80 beats per minute. Systolic blood pressure more than 80 mmHg. Pupils which are no longer pinpoint, that is dilated, mid-dilated pupil, and the dry axilla. First 3 points are the most important points for atropinization, that is target endpoints, that if these are present, we can stop atropine. Once the patient is stable, we can start infusion of atropine, that is every hour we have to give 10 to 20% of the total dose needed to stabilize the patient. Along with it, we have to watch for atropine toxicity, that is if patient is having any fever, patient having tachycardia, absent bowel sounds, or the urinary incontinence. If this happens, we have to stop the infusion and wait for 30 to 60 minutes for these features to settle before starting again at a lower dose. Adverse reactions to atropine. Two types of adverse reactions to atropine can occur, that is allergy and the toxicity. Toxic results mainly from the anti-muscarinic effects which can vary from person to person depending on sensitivity to atropine. Allergic reactions are rare, which are local manifestations after administration of eye drops, and systemic manifestation in form of anaphylaxis. Atropine toxicity. Atropine toxicity is not uncommon with OP poisoning, which is manifested as tachycardia, tachypnea, increased body temperature, and the CNS stimulations like restlessness, confusion, psychosis, and the delirium. Seizures is rare manifestation of atropine toxicity. If these are present, then we have to switch over the glycopyrrolate, since glycopyrrolate doesn't penetrate CNS and doesn't have this CNS manifestations. Small doses of benzodiazepine may be required, and in severe cases haloperidol can be used, but there is a risk of neuroleptic malignant syndrome with haloperidol. Glycopyrrolate does not enter CNS, so initial muscarinic signs like coma or drowsiness might not be responded. Its use is recommended when there is copious secretions as an adjuvant to atropine, when there are features of atropine toxicity like delirium, which are confused with the CNS effect of poison. When atropine is not available, then we can go with glycopyrrolate. Dose of glycopyrrolate is 7.5 mg in 200 ml of saline, started as an infusion and titrated to the desired effect of dry mucous membrane. Neutralizing toxin, that is oxime therapy. Oximes act by reactivating acetylcholine esterase that is bound to the organophosphorus molecule. Pralidoxime is the most frequently used oxime worldwide. Other are obidoxime and the trimidoxime. The therapeutic window of the oxime is limited by the time taken for aging of the enzyme and the organophosphorus complex, because aged enzyme can no longer be activated by the oximes. Dose for pralidoxime is, WHO recommends pralidoxime dose of 30 mg per kg bolus IV over 20 to 30 minutes, followed by infusion rate of 8 mg per kg per hour. Infusion is continued until recovery, that is 12 hours after atropine has been stopped and the butyrylcholine esterase activity is noted to increase. Largest oxime that can be given is 2 gram loading dose, followed by 500 mg per hour maximum for 5 to 7 days. We should avoid rapid administration of pralidoxime because it can lead to tachycardia, laryngospasm, and the muscle spasm and transient neuromuscular blockade. Other adjuvants which can be used for the treatment of organophosphorus poisonings are magnesium sulfate. It acts on the calcium channels, which further leads to decrease in the acetylcholine release. It decreases the CNS overstimulation by acting on NMDA receptor also. It is given in a dose of 4 gram on first day, and it has shown to decrease hospitalization period and overall improvement in mortality. Diazepam, as such, diazepam has no role in organophosphorus poisoning, but is mainly used for seizures, which can occur as organophosphorus organophosphorus side effect or atropine toxicity. Its dose is 10 milligram IV slowly, which can be repeated up to 30 to 40 milligram over 24 hours. Clonidine, it is alpha-2 adrenergic receptor agonist. It reduces acetylcholine synthesis and release from presynaptic terminals. Its dose is 0.15 to 0.3 milligram IV bolus, followed by 0.5 mg over 24 hours. Charcoal hemoperfusion, its benefit is mainly shown in patients who present within 6-4 hours. After 24 hours of presentation, it has no such benefit, which is seen in most of the trials. Lipid emulsions, albumin, and the FFP has as such no such benefit. Some study shows benefits, some study shows no benefits of these compounds in treating organophosphorus compound. Worldwide mortality of organophosphorus poisoning is 3 to 25%. Mortality rates mainly depend on the type of compound used, the amount ingested, general health of the patient, delay in discovery and transport of the patient to the required to the tertiary care hospital, insufficient respiratory management, delay in intubation, and failure in weaning of ventilatory support. Thank you.